Hello, everyone. My name is Balanha Ogunbayo from the University of Kentucky, and we are at ACC.17. And we have with us today at the Fitz Lounge Dr. Mark Sabatine. He's the chairperson of the TIMI study group. You're very welcome, Dr. Sabatine.
Oh, well, thanks for having me here. It really is a pleasure to be here.
And that was an excellent presentation you gave earlier on about the FOURIER trial.
Oh, well, thanks. I'm very glad you were able to attend it. We were very happy with the results.
Piggybacking on that, I'd like to ask to kindly tell us a little bit more about that trial.
Sure. So FOURIER was a large, dedicated cardiovascular outcomes trial looking at the PCSK9 inhibitor evolocumab. We enrolled over 27,000 patients with known cardiovascular disease, either having a prior MI, a prior stroke, or symptomatic PAD. They all were to be treated with optimized lipid-lowering therapy, preferably a high-intensity statin, but at the very least moderate intensity, with or without ezetimibe. It turns out the baseline LDL cholesterol was around 92 milligrams per deciliter, and then we randomized them to receive either evolocumab or placebo. We followed them for between 2 and 3 years, and we found that evolocumab significantly decreased the risk of the primary endpoint, a broad composite of cardiovascular outcomes, by 15%. We were particularly happy to see an even greater risk reduction, a 20% reduction in the harder secondary endpoint of CV death, MI, or stroke. We were happy that the results were consistent in all the subgroups we studied, interestingly, including patients who were in the lowest quartile of LDL, which was less than 80 milligrams per deciliter, and it turns out those individuals started with an LDL of 74 milligrams per deciliter, and they benefited. Evolocumab got it down to 22 milligrams per deciliter, and a significant reduction of events in that group. And also, like what has been seen in the statin trials, the benefit grew with time, so that overall 20% reduction in CV death, MI, and stroke was actually a 25% reduction after the first year. And luckily, in terms of safety, the compound looked very good, no major side effects, and unlike other compounds in this class, there was no development of neutralizing antibodies, so very reassuring.
And it's also very reassuring that the Ebbinghaus trial that I believe will be talked about tomorrow also kind of echoes that in terms of the fears that we've had about PCSK9 inhibitors before.
Yeah, no, I think that's right. There had been in the literature concerns either about statins or about low LDL cholesterol potentially being associated with side effects. Certainly myalgias have been described. There does appear to be a link between statins and diabetes. There was a concern for neurocognitive side effects with statins that's never been well shown, and also a concern for the PCSK9 inhibitors based on some small amounts of data, as well as cataracts seen in some studies for statins. But we didn't see any of those. Now, Ebbinghaus is the dedicated neurocognitive substudy, so the neurologic side effects we talk about are adverse events reported by patients. Ebbinghaus actually uses a tablet-based approach to test cognition. That was done in just under 2,000 patients. And my friend and colleague, Dr. Bob Giuliano, will be presenting that tomorrow morning.
Thank you very much, sir. Now, given the expected vast impact that this study will have, how do you think, or how do you suggest or expect that it would affect the use of PCSK9 inhibitors going forward?
I think it should increase their use. I think many of us who firmly believed in the LDL hypothesis and were convinced by the Mendelian randomization studies for PCSK9 already had embraced them, but understand that other people wanted to wait for the CV outcomes trial to see if there was a reduction in hard outcomes. And now the answer is yes, that there are. So I think people should be adopting the use of PCSK9 inhibitors.
Yeah, and referring specifically now to fellows in training, how or what approach do you think we will or should take in including PCSK9 inhibitors in as far as management of our patients with high-risk conditions for cardiovascular disease, and also patients that have had ACS?
No, we absolutely actually count on the fellows to help keep us from being ossified and move the practice along. And so I always love, whether it's a fellow in the CCU or precepting a fellow in clinic, The fellows are the ones to be reading the literature and remind us that we need to stay up to date. I think, when I went through training, there just was the data coming out for more intensive lipid lowering, and actually before Prove It TIMI 22 came out, people had advocated treating aggressively with statin therapy, and that's something we adopted as fellows to treat patients with atorvastatin 80 as soon as they came in the hospital. I think you're now growing up in the era where we have not only the data but now the tools to show the benefit of getting LDL cholesterol down to the 20s. So think back to when 4S was done, when the question then was, we have individuals who've had an MI and their LDL is 180 to 190. Should we do anything about it, right? That would be heresy to you now, right? Then Dr. Brunwald led the CARE trial saying, well, what about average cholesterol of 125? Do we need to treat that? Of course we do, and that was successful. Then we showed in Prove It TIMI 22 that you should drop patients from 100 down to 70, and then we showed in Improve It from 70 down to 50. Here we showed dropping patients down to the 20 to 30 range, they benefit. I hope that's going to sink in and be embraced by the fellows, and you'll be the voice going forward that LDL cholesterol is a major risk factor, and we need to get it down to decrease our patients' risk of heart attack and stroke.
Thank you very much, Dr. 17.
Great, thanks for having me.
For more information, please go to youtube.com/feedsonthego.